Thanks, Allison, and thanks everyone for joining our Express webinar series related to the changes that are Medicare's enforcing January 1st, 2015, related to the utilization of the Modifier 59. As we know, the Modifier 59 is used to identify procedures and services outside of the E&M service range that are not normally reported together, but are appropriate under the specific circumstances of the encounter. So this is a very vague definition, and due to the definition, the 59 modifier itself allows usage in a wide variety of circumstances, and is really a catch-all applicable modifier, and is often referred to as the modifier of last resort, which allows for a bypassing of the National Correct Coding Initiatives, the NCCI edits and rules, which then lead inherently, it invites misuse and abuse. Historically, the Modifier 59 has been the most frequently used modifier within the HCPCS modifier category, and subsequently generates the most payer audits. An OIG report of 2005 found that 40% of the modifiers utilizing claim 59 modifier failed to meet the CMS program requirements, resulting in an estimated $59 million in incorrect payments. More recently, in 2013, a CERT report projected that a one-year error rate of $770 million on incorrect modifier utilization was made throughout the course of the year. As a result, Modifier 59 is a frequent target for payer audits and has appeared in the OIG's annual work plan every year for a decade. So in order for Medicare to prevent this, they're putting new rules in place. The changes are going to be implemented the first of this year. And what the planning is for more accurate coding options and selective editing in order to minimize these errors that they've seen throughout the reports and audits that have been conducted with the use of the 59 modifier. Now, the intent of the four newly introduced modifiers, which we'll go over in a second, commonly referred to the X-ESPU modifier, is to require providers to really specify the circumstances that are calling for the separate reimbursement on reported services. Now, it's important to communicate that CMS is not going to stop recognizing the 59 modifier. However, they are going to be looking for more descriptive modifiers should they be appropriate during the course of the stay and the course of the billing. So what that pretty much is telling us is that they're still going to accept the 59 modifier. They're not going to reject it at claim submission, but denials are going to increase, looking for a more specific determination of the modifier utilization. So I want to move in a little bit. We'll talk about the modifier X-ESPU. There's four separate modifiers, all of them starting with an X. The XE designates a separate encounter. This is a service that is distinct because it truly occurred on a separate encounter. And as I go through these, I'll give some specific examples that will give a little bit more clarity on each of these modifiers' utilization. The XS is on a separate structure where the service is distinct because it was truly performed on a separate organ or structure. XP, that of a separate practitioner, where the services were distinct, they would still hit the bundling rules, but because of the nature that they were performed by a separate provider, would qualify for separate reimbursement. And then the XU, which is the unusual non-overlapping services, and these are services that are distinct because they don't overlap usual components of the main service. And that one's a little bit trickier, but as I mentioned, we do have some specific examples that we'll go over right now. So within the XE modifier of the separate encounter, an example of this is where a patient would come in and receive services early in the morning, such as antibiotic services. They're going to leave the facility, and then they're going to come back for another infusion later in the day. Since both of these services are unique and distinct, and they should be reimbursed separately, the utilization of the XE modifier being on the same day should be used to indicate that it's performed as a separate encounter. Now, obviously, the documentation needs to support the utilization of this as well, but that's an example of where the XE modifier should be used in replacement of the 59 modifier. And looking at XS, this is where the performance of the procedure is done on a separate structure. An example of this would be a skin lesion that's destroyed via laser surgery from the arm. and another lesion during the same episode of care has been biopsied from the leg. Since the arm and the leg are two separate structures, the utilization of the excess modifier associated with the lesion biopsy on the leg would be appropriate to designate that it was performed on a separate anatomical site and thus qualifying for separate reimbursement. In looking at the XP, this is where a separate practitioner, an example of this would be, surgeon A preferred laparoscopic hernia repair early in the morning. Towards later part of the day, the patient had to go back to surgery. Surgeon B performed the appendectomy. The XP would be utilized on the laparoscopic appendectomy to show that a separate provider performed this service and that the bundling rules should not apply because they were two separate encounters by a separate practitioner. In looking at the XU, these are unusual and non-overlapping services. An example of this would be two separate lesions that are present within the same code set and are excised separately, i.e. a 4 centimeter lipoma on the upper thigh and a separate lipoma excised on the lower leg. Since these are unusual and non-overlapping services, the XU modifier would be appropriate to use on the excision of the lower leg to be able to designate that the services are not overlapping on a separate region and thus would be reimbursed on a separate level. So what does this mean for you? So as we go through it and we're looking at the claims, as of January 1st, 2015, claims are going to be accepted and processed by Medicare containing these new modifiers. As I mentioned before, the 59 modifier is not going to be rejected. However, starting at the beginning of the year, Medicare is going to start looking for the more specific modifier to designate that the service is a separately reported event. What you'll start seeing within the MD Everywhere solution is our edits are going to be applied to claims qualifying for or containing an XPSU modifier in the same manner as the edits would apply to a line containing a 59 modifier. So our edits are in the system now. If the utilization of a 59 modifier is going to be required, or if you code a 59 modifier, you're going to start seeing edits that are going to be asking for more specific examples of the X-modifier subset, and then bundling edits or NCCI edits that hit previously where the 59 modifier would override it are now going to be looking to qualify the X-level modifiers moving forward in order to be able to bypass that edit and get the claim out the door. So one of the things that we should anticipate moving forward in January is an increase in the denials related to the documentation. I would anticipate that we're going to start seeing more rejections from Medicare looking for specific documentation that's going to support the more specific modifier designation moving forward. So I hope this was educational and knowledge-based. Obviously, your account executive will be available and will reach out to you to further reinforce some of the rules and edits that are going to be in place within our Practice First system. As well, if you have any questions, you can leave them to the webinar, and we will respond back to you on any questions that you may have related to the changes coming forth in the 59 modifier. I want to thank you all again for attending, and this will conclude our Express webinar series on the 59 modifier changes for Medicare.